The immunotherapy for multiple myeloma has significantly transformed the field over the past few years with high rates of responses, which are quite deep and appears to be fairly durable in a relatively late relapsed refractory setting in multiple myeloma. In particular, at the ASH 2020, we saw results from 6 different CAR T products, including some allogeneic CAR T as well as CAR T setup manufactured using different technologies. CT053 is the CAR T cell that was studied in the Lummicar-2 trial, and the Lummicar-1 trial was the initial trial that was done in China looking at the dose escalation of CT053. The Lummicar-2 study is designed to examine increasing doses of the CT053 CAR T cell and to recommend a phase 2 dose that will then move forward into an expansion phase. The CT053 is a BCMA targeted CAR T cell. Again, has autologous CAR T cells. The study design used 2 different dose levels. So patients, after they undergo screening and apheresis, they are allowed to receive bridging therapy with one regimen that they have previously been exposed to if needed. And then these patients will undergo lymphodepletion with fludarabine and cyclophosphamide, followed by reinfusion of the CAR T cells. We presented the results of the first 20 patients that were treated on this protocol at the ASH meeting. 14 patients received the lower dose of 1.5 to 1.8 times 10 to the power of 8 CAR T cells, and 6 patients at the higher dose of 2.5 to 3. The trial showed that the patients had relatively rapid and deep responses to the CAR T cell. Amongst the 18 patients in whom the response could be assessed, 17 of those patients actually had a partial response or better, including 10 patients who had a very good partial response or better. What we noted was that the bone marrow was cleared fairly rapidly of the plasma cells in majority of these patients, and we also saw a relatively rapid decline in the serum BCMA levels and serum free light chain levels. The monoclonal protein also decreased over time, showing deepening responses. In terms of tolerability, we saw mostly grade 1 and 2 cytokine release syndrome, and this was quite comparable to what has been reported with other CAR T cells. We saw 3 patients with neurological toxicity, again, mostly grade 1 grade 1, 1 grade 2, and 1 grade 3. The timing of onset of the CRS was in the first 3 to 4 days. We also saw that the CAR T cells expanded nicely with a peak expansion at 7 to 14 days from the infusion. The trial is now still ongoing, and we are accruing more patients to the phase 2 portion of the trial. And this will give us a better estimate of the efficacy of this particular CAR T cell. One of the advantages of the CT053 is that it has a relatively shorter manufacturing time compared to some of the other CAR T cells, with a turnaround time of about 7 to 10 days, which can significantly decrease the vein-to-vein time in the setting of CAR T cell therapy.